First of all, acute DVT is the most dangerous, right? And the reason is because it's brand new, so it's not attached to the wall, right? It's a brand new DVT, right? So if it's not attached to the wall, then it can break loose. So that's why acute DVT is more dangerous. It's less than how many weeks? 4. It's brand new, it's free floating, and it can break loose. Now, what about the ultrasound side of it makes acute DVT more dangerous?
Press down.
Someone said it's anechoic. And that's right, Larry. So when you push on it, you're not going to, because it's anechoic in like a normal vein. So you'll push down and you can throw it, right? So ultrasound-wise, an acute DVT is more dangerous because it's anechoic, so we can't see it unless we put color on it, right? So that's why it's very important next quarter when we start doing legs that we put color on it and press. So acute DVT is more dangerous because it's new, it's not attached to the wall, and it's anechoic. So as far as our job goes, if we don't put color on it, we'll push down on it, okay? Then you have the next category, which is subacute. Subacute is the one that's 4 to 12 weeks, okay? With a subacute DVT, the vein is normal, still normal size, but there's something you start to see inside of the vein, right? With subacute, you start as thrombus ages, it gets brighter. The subacute, the vein looks normal as far as the size of it, but you can now see the thrombus starting to calcify in there, okay? The subacute is 4 to 12 weeks. It's not as dangerous because as the ultrasound side of it, we're not going to push on it because we're going to see it in there, right? So, but it's still more dangerous than the next category, which is chronic. And chronic is the one that's been there for more than 12 weeks, so that's more than 3 months. And because it's been there so long, it starts to attach to the wall. So you're not going to, you can push on it all day long if you want to, you're not going to break it, okay? So if you go in there to scan it, you're not going to push because you're going to see it, but you could and it ain't going to matter, all right? So chronic DVT is the least dangerous. It's been there more than 12 weeks. It's firmly attached to the wall. And normally what does the vein start to do with a chronic DVT? It starts to contract and get smaller. So with a chronic DVT that's been there for multiple amounts of time, sometimes the vein, you won't even see the vein, it'll be so small, okay? So acute's more dangerous, less than 4 weeks, brand new, it's free floating, it's anechoic. We can push it, we can throw it, okay? So use your color. Subacute is 4 to 12 weeks. The vein is normal size, but it starts to see the thrombus within it, so we know as a tech not to push down on it. And then chronic is the least dangerous because it's been there for more than 12 weeks. It's firmly attached to the wall. We can push on it all day long, and it's not going to break loose, okay? Some ultrasound findings that you will see with a chronic DVT is it actually, because the vein gets smaller, the thrombus doesn't get smaller. The thrombus just continues to get bigger. So over time, the thrombus is going to fill in the vein, and there's not going to be any flow going through that vein. And we were talking about collaterals forming around the vein, or recanalization, which is like a worm digging a tunnel, okay? So chronic DVT can form collaterals or can recanalize to get blood flow around that vessel. All right? Just wanted to be sure we knew the differences. And then as far as the risk factors go, it could be post-op, pregnancy, birth control, trauma, previous DVT, cancer. Some people were putting like limb swelling. That's not yet. Redness and warmth. Those are symptoms that the patient is having because of the DVT. They don't cause, that's not a risk factor for DVT, okay? So know the difference between a risk factor, what can be going on within the patient's body to make them have a DVT, and then the symptoms that the patient would be having, which would be the swelling, the redness, and the warmth. Okay, those are differences there seen. And types of flow that you should see superior to the calf, spontaneity and respiratory toxicity. Some people think it was funny, but antegrade and retrograde. You know, better than nothing, but spontaneity and respiratory toxicity is what you should see in all the veins superior to the calf. So top, vein, and up. That's what you can think about. Okay, respiratory and spontaneity. You did, that's all. It was cute. Alright, and then when you get to the smaller, to the calf vein, you lose the spontaneity. Why? Because the veins are so small, now you have to squeeze your foot, or squeeze and augment and get flow to come up. So respiratory and spontaneity persistence should be seen on all veins superior to the calf. Alright. Any more questions that you can think of about DVTs when we talked about them? Just big thing to remember is if you lose your respiratory spasticity, you look proximal on that patient. So if the flow becomes more of a continuous nature, look proximal. And if you lose spontaneity, look distal. Because that will be on your final next week. I'll say while scanning the common femoral, I noted there's no, I noticed a loss of spontaneity, and you'll know you need to look distal. You'll pick the distal vein, okay, something like that. That would be worded. Be sure you note that. All right, I just wanted to go over that. Now, today's quiz was interesting. Okay, we're going to go over that today because we only got like 3 pages in the book and we're done. The reason I've done it like this is because it uses those fancy words, critical thinking, and you got to really know your anatomy. It's better than harder, but it's better for y'all than seeing it and you have to fill in blank. Okay? So if you are doing arteries and you're starting with the aorta, what does aorta bifurcate to? Common iliacs, right? What does the common iliac bifurcate to? Internal and external. Okay? The external continues down to form a V. Common femoral. Right? And then common femoral forms deep and superficial. Superficial forms pop. What's the first branch off the pop? Okay, what does the anterior tibial artery turn into? Remember the new word. What is anterior tibial? Dorsalis pedis. Remember that word? Almost everybody missed. I didn't take that off first, but remember anterior tibial artery turns into dorsalis pedis.
I thought it came from the posterior.
I didn't.
So I thought it came from posterior.
No, anterior tibial. Yeah. So what's the second branch off the pop? The trunk, and almost everybody missed trunk. And if you missed it, it was the whole thing wrong, okay? Just so you know. And so what does trunk turn into? Posterior perineum. And then you're done with the artery. Okay? Some of y'all added in the plantar arches, and that's totally fine. I mean, that's where it's going to stop there. All right, so what 2 veins form the trunk?
Perineal.
Posterior tibial vein, that's where I said y'all start at, right? Then start at the perineals and posterior tibials, and then a hint, you're going to end at the IVC. So perineals and posterior tibials form the trunk. What 2 veins got to join together to form the pop? Anterior tibial and the trunk, right? And then you get to pop. Pop turns into superficial. Superficial is going to join deep to make common femoral. Common femoral turns into external. External join internal. They make iliac. Common iliac turns into IVC.
Easy when you're
That's it.
There's a couple.
I thought it was posterior.
I couldn't remember another name for
Some of
it.
these diagrams,
They have-
yeah, some of these
It's Palmer.
diagrams, we know it's like,
Yeah.
not exactly correct.
And then when I looked,
I
I
couldn't
was
remember,
like,
first I couldn't remember
Turns
Palmer.
into
I
dorsalis
just put
pedis.
Bowler.
Yes.
Because it's both.
only reason I know Palmer is Palmer.
Bowler. So I was like, Bowler. And then I'm like, wait a minute. But,
And I remember plantar because you plant your feet.
I missed the, which was Clay, I put left, I couldn't remember, and I get, I got 50%.
It was left. It was
It's left, and I
Yeah.
put, and I put.
So, whenever we're on that, we don't need to list the greater
Like, you know, you got
No,
50%,
because
and I
those are
can't even get
official
that.
What?
That's where we're going
I hate
now.
shrimp. I was too. You got 50/50.
What are the superficial veins in the legs? Nobody got this. Maybe one person. Greater staff and the lesser staff.
Yeah.
What if you added the wheel, just because I did? Because I couldn't.
And then the superficial veins in the arms, we didn't talk about, so I'm gonna talk about them right now. You have two of them, just like you do in the legs, okay? And they're called the cephalic, which is C-E-P-H-A-L-I-C.
Let me say it not that.
Cephalic and basilic, B-A-S-I-L-I-C. Basilic, okay? So cephalic and basilic are the superficial veins in the arms.
Have we already went over that?
I thought I was supposed to tell y'all that and I didn't.
Oh, so we got it right.
Yeah, somewhere.
You think it's wrong?
Yeah.
So-
I thought you said it was in there.
It's in the book somewhere.
How you spell basilic? I'm sorry.
B-A-S-S, B-A-S, basil is I-C.
Like the basil leaf?
Basil, there you go.
No, basilic, B-A-S-I-L-I-C, I think. Anyway, cephalic and basilic. That's spelled it. And I'm sure I'm wrong. Now, what you need to know about them, just like the greater saphenous joins into common femoral and lesser staph joins into pop, cephalic and basilic join in somewhere also, okay? So, the cephalic is your lateral branch over here.
Which one's the?
Cephalic, it's your lateral superficial. It joins the deep system at the axillary vein. So the cephalic comes all the way up, joins in at the axillary vein. And cephalic joins into the axillary vein. And then basilic joins into the brachial vein.
The medial branch.
Yeah, your medial superficial vein is your basilic, and it joins in the brachial vein. That's where it joins into the deep system out. Okay? So I know as far as, I'm pretty sure your test is going to read like the cephalic and the axillary vein form what vein? Think about it. What comes before axillary? What does axillary turn into? Subclavian, right? So the cephalic and axillary join to form subclavian, right? Just like veins in the leg, but join to form, okay? And then the basilic and the brachial join to form what?
Radial.
Nope, because you're going up, axillary. Yep, very good. So basilic and brachial join together to form axillary, and then cephalic and axillary join together to form subclavian. These veins are going up. The GSV and the LSV, greater staph and lesser staph, or short staph, depending on what book you're reading. Soleals, they drain to the posterior tibial and perineal. They're calf veins. And they are the most common, there you go, because it's going to be in your test next week, the most common site for DVT to start. Yes. You're right. Alright, so again, cephalic's your lateral, and it joins into axillary to make subclavian. Your basilic's your medial, it joins into brachial to make axillary. And then, which subclavian artery ends at the thoracic outlet? Left. What are the three branches off the aortic arch? Nominate, left CTA, left subclavian.
I did the, oh man, I did that.
Right? Thank you.
Now, if I breathe, it helps.
What?
Because I did off the,
She's better silly, I guess, than May Green.
If I breathe, it would help, wouldn't it?
That's okay.
That would help a lot.
You should change the question.
Yeah, that's a good question.
Yeah, I know, I was hoping.
The more I feel, the more there's something on there.
What are the arches in the hand called? The
Palm.
palmer. What are they called in the feet?
Plantar.
Plantar. And what's another name for the arches in the hand? Volar.
I didn't remember that.
Yeah, I did not remember that.
Volar.
And she actually ripped, you actually.
Yeah, and it's actually right here also.
Well, I'm so glad you
Here.
got
I got that.
Six.
Yes, ma'am. Okay. And then 3 layers, everybody got this, intima, media, and application.
Goodness. So we can't change that question. All right.
Everybody's dying.
We can't just answer what we want to do.
Everybody's been sick for a long time.
I think Clem did it. She didn't go to the doctor. I was sick. Clem was sick.
She was the first one sick. And hers only lasted like 2 days.
I had some weird strains of pneumonia, and it's called like myoplasma.
Everybody, American Family Care Facility, but you can only get from kids.
I don't know, but anyhow, but I was off all week, and then I got trouble being off, so anyway.
How are you gonna get trouble right for being
Because
sick?
I told y'all that we get trouble when we're out. So, nobody can miss any work or school.
The way it's supposed to come and just.
That's why we're all sick.
Yeah.
Yeah.
Against the rules. Very good. All right, what page did we get to? I know we almost finished it, I just had to stop, but I'm about to set that on y'all. Okay. Yeah, we finished 29, didn't we? So we get to skip all the way to 37.
Dang, I missed that. I missed that. Yeah, the celiac question. Help if I read. That burns me when I
I
do
put
that.
A down, I put. Yeah, you're not changing.
That burns me if I mean, it's my fault. I just wish I'd read, you know? I just read.
Public school.
Oh, Lord, there you go. I'm gonna blame myself.
We never did anyway.
So do your kids celebrate Hanukkah, or do they?
I try to make, I don't make them.
Right.
Their mother.
Kind of encourage it, like.
I go, hey, happy Hanukkah. You know.
Yeah.
It doesn't make me.
Have fun.
Does she fight
It
about
really
it? I mean, she doesn't fight about it, does she? Like, don't tell her mother, you know? Do you do like, presents, you know, like, isn't it like presents you send a present?
Exactly. I'm just getting hard. Yeah, 'cause then I, you know,
Well, my sister's husband and I was telling you, and she was trying to explain it to me a long time ago, they've been, like, this wasn't huge presents, usually, but there's like little presents, is that right? Or, it wasn't like you get an Xbox or or, you know what I mean, or.
All right, 37 talks
Different
about
norm.
It
collateral,
just depends.
and we know what collaterals are, they're your body's own bypass graft, okay? They can form with arteries or veins, either one. So, there you know about it. 'Cause this is more important for vascular surgery, but that's all I want y'all to know. Your body's own bypass graft, they can form with arteries or veins, okay? Huh?
I might be retaking that question today on for that next round.
And then the next page, it goes over what happens when we exercise, and I think we've discussed this before, but when you exercise, your muscles need more blood flow. So are you gonna dilate or constrict to get more blood flow? You're gonna dilate. So exercise induces vasodilation. And it says on the 3 little paragraphs past that, the exercise is the best vasodilator, okay? So that, I know that'll be a test question. Exercise is the best vasodilator. And then you can go back up again to the second little paragraph. It says, peripheral resistance. The resistance to blood flow caused by the decreasing size of vessels, It will change in response to stimuli. So it doesn't have to be plaque or stenosis that causes your vessels to constrict or get smaller. Other things can be if you're hot or you're cold or you smoke or you're stressed out. Okay? So if you're hot, you think that your vessels are going to constrict or dilate. Exactly. Let the heat out. If you're cold, constrict. Okay? Smoking constricts your vessels. That's why Raynaud's, Berger's disease. I've seen the commercials for Berger's disease. It's just a constant constriction if you're a heavy smoker. So every time you finger your hose or whatever's being constricted, it's going to eventually fall off or have to be removed. And then emotional stress. What happens when you get embarrassed? What does your face do? You dilate. It turns red. Very good. It says constriction and dilation of the blood vessels within skeletal muscles. They help to regulate your body temperature. So constricting and dilating helps to regulate body temperature. Just like we said, if you're hot, you dilate to cool yourself off. If you're cold, you constrict to warm your body up. Okay? We done talked about exercise being the best vasodilator. And then autoregulation is next. It controls constriction and dilation. And it helps your body to maintain a constant level of blood flow. That's what that one does. Here's a big old paragraph. By decreasing resistance in a working muscle, exercise normally decreases reflection. A low resistance monophasic signal may be present normally in an extremity after exercise, right? Because if you exercise, you become low resistance. Because the exercise causes peripheral dilatation and causes a reduce in your resistance. And that's as far as y'all need to go. Remember, this book is used for vascular too and your registry. So as far as I need y'all to go right now. For all these places where we're skipping over, we'll catch up because my whole book's highlighted. We'll catch up to it eventually. And then on page 39, when you're doing any type of testing, it says the second little bullet, questions need to be asked. Was the extremity cold or warm? If it's cold, it's going to be more of a high resistance waveform. If it's hot, it's going to be more of the low resistance waveform. Has it been exercised? And then flow to a cool vasoconstricted extremity will have pulsatile signals. Flow to a warm dilated extremity will have continuous signals, right? Okay, so ICA is more low resistance, think of that waveform. ECA is high resistance, is more pulsatile. And then the last thing is effects of stenosis. Okay, laminar flow. Remember, laminar flow is a normal type of flow, right? And you have plug and parabolic. It says laminar flow is even distributions of frequencies at systole with lowers at the wall. But remember, which one was it? Was it plug or parabolic that is the same speed no matter if it's at the wall or center? I can't ever remember. Is it parabolic?
One's like a flow.
Plug flow. Plug flow is the one. It's this type of laminar flow, but it's fast no matter if it's at the wall or the center. So just remember that. Even though it is considered laminar flow, it doesn't matter where you're at. It's going to be the same speed. Of course, when you have a stenosis, it says a hemodynamically significant stenosis will cause a reduction in the volume, flow, and pressure. We know that, right? If flow and pressure go down, what goes up? And resistance. Very good. Okay. A stenosis usually becomes significant when it says a cross-sectional is reduced by 75%, which corresponds to a diameter reduction of 50%. Diameter reduction is a one-dimensional measurement, so you do it in long, okay? And then area is two-dimensional, so that's when you measure, remember, true lumen versus residual lumen, okay? So that's an area reduction, so you would do it in transverse. And there at the bottom is a diameter reduction. The vessels lengthen out. They're measuring the left, the vessel that's left by plaque, so that's their diameter reduction. And then, of course, we've looked at true lumen versus residual before. There's a little diagram right there. You can flip over to the next page. the very bottom, it says proximal to a stenosis flow usually becomes dampened. Y'all remember talking about that? Okay. So proximal to a stenosis, your flow becomes dampened. And then as flow enters the stenosis, what happens? Velocities increase, because what's increasing? Resistance. Yes, resistance is increasing. And then on the next page at the top, post-night turbulence is seen right after a stenosis, correct? Because remember what happens when you exit a stenosis? The pressure goes up, but the flow hasn't met yet. Because of the increased pressure, it's very chaotic flow. Then on down, then pressure and flow become normal.
What's that called again, something?
Eddy flow, eddy current, post-night turbulence, it's got multiple words. Alright. Well, that's it. That was lovely. Lovely. So, Wednesday, don't forget, we got cards, and we got speakers coming.
And then final.
Final next week. Monday we'll be scanning.
Okay.
Wednesday we'll be written. What did you say?
Oh, don't forget to turn in your presentation.
And don't forget to turn in your presentation Wednesday. That's right.
But we can turn it in today, right?
Yeah.
Okay.
You already did it.
What? Yeah.
And everyone.
Hey,
Brooke. Miss Curran told us that we were scanning, unless you wasn't supposed to.